Hello, welcome to another session of Digital Slide Review and Sign Out. I'm Dr. Louis Hassel, and as you can see, I'm coming to you from the University of Oklahoma Medical Center, a health sciences center located in Oklahoma City. Our program is part of the Digital Anatomic Pathology Academy, a joint venture with Path Presenter and the Digital Pathology Association. Today's case brings up some interesting points in the realm of GI pathology. The patient is a 65-year-old man who's being seen in follow-up, having had a prior diagnosis of Barrett's esophagus and being status post radiofrequency ablation. So just to review, for those of you who don't practice GI pathology, radiofrequency ablation involves the insertion of a specially designed catheter or endoscope into the affected portion of the distal esophagus. And then the balloon is inflated, and it's a specially equipped expanded balloon with the ability to deliver a radiofrequency that essentially cauterizes or burns the mucosa around the full circumference. It's important that this not be done for nodular lesions because there's obviously a very limited depth of penetration of this energy. And then, of course, this can be done over a number of segments over time, potentially, until a proper result is obtained. Now, obviously, there are complications. No procedure is entirely risk-free, but most of the patients avoid the need for significant surgery if they have this performed. But there's a percentage, depending on the severity of the specific complication in question, maybe up to 10% or more that may suffer some sort of a complication or less than optimal outcome. Studies that have looked at this have taken sort of two tacks. One is looking at what happens histologically over a 3-year period of follow-up. And as you can see, greater than 90% of those with intestinal metaplasia have a complete response, with 7 here in this first group and 5 in the second group. That had relapse of intestinal metaplasia. In the setting of high-grade dysplasia, fairly similar results. 50 out of 54% had good response, complete response at year 2, and 23 out of 24 by year 3. And fairly similar or even better numbers for low-grade dysplasia. I will point out, however, that up to 3.8% of patients have buried Barrett's esophageal mucosa that is identified in follow-up outcome. Occasional cancers have been reported, and there may be progression to a slightly higher level, leading to the observation that about half of these patients either initially or subsequently require some sort of a touch-up follow-up of the ablation. So here's our biopsies. Our patient, as you can see here, has squamous mucosa, and obviously we've done a little bit of an EMR because they detected a small area of residual glandular mucosa here. And as you can see, it just has maybe a suggestion or two and a couple of cells here of goblet cells. So intestinal metaplasia persists in this patient, and you see the altered vascularity that can be associated with this and can help to highlight the lesion. So appropriately, this was excised. However, as we examine the other specimens here, we note that particularly here, in contrast to what we saw there, these glands are beneath a squamous mucosa. And that's a concern because these buried lesions can be very difficult to detect with simple optical endoscopy techniques. The other thing to notice here is the nature of these glands. So first of all, they're a variable size. We have one gland here with a little bit of a stromal response and some nucleoli. As we look at these other glands, we see the nuclei are crowded. There's a mitotic figure. We have some inflammatory debris beginning to accumulate in the lumen. Here, some apoptotic cells. And the shapes of these glands are variable. The NC ratio is high. So what do we do with this? Well, this is certainly a point in time where you want to consult with your colleagues and get their sense and appraisal of these lesions. Our impression was that this represented at least residual high-grade dysplasia, very concerned about little structures like this and like this that could represent carcinoma. Fortunately, in this situation here, this other section here, other gland here, we could determine that this was still within the lamina propria, was not beyond the muscularis mucosa. We have a few strands of muscularis mucosa here. So this is still entirely curable, but the problem, of course, is complete detection. And so finding that in this circumstance certainly is going to warrant further follow-up of this patient to see if there are other other areas that can be detected. And of course, you do worry about that because little small glands like these may be extraordinarily difficult to detect by conventional endoscopy. Advanced imaging, endomicroscopy, in vivo microscopy, other sorts of things where you can get a little bit of penetration beneath the surface may be required to detect these lesions. Well, the overall experience with this buried dysplasia is an interesting question. There aren't a lot of cases reported. This series published a couple of years ago reviewed the literature and sort of brought together about a dozen cases here. And as you can see, about half of them, the recurrent dysplasia or adenocarcinoma occurred with a flat mucosa. Just as what we had seen in our area. If you have a nodule, maybe that's a little bit easier, but even in these flat mucosal lesions, adenocarcinomas were accounted for half of those cases. So not an insignificant potential for even flat lesions to represent invasive adenocarcinomas. The other point to take note of is the duration post-RFA to the time of detection. And as you see, we have detection sometimes 3-6 months, early follow-up, but we also have several cases that are 2 and 3 years or longer beyond the time frame of that initial RFA. So that means these patients do need to continue to be followed, especially if they have had initially high-grade dysplasia or other types of lesion. We do see some progression from low-grade to high-grade in some circumstances, or from high-grade to carcinoma, so that's to be expected. But follow-up is the key here for these patients. And that means the pathologists are going to be involved. So our final sign-out diagnosis today is buried high-grade glandular dysplasia in a patient's status post-endoscopic radiofrequency ablation of Barrett's esophagus. Well, thank you for joining me for this intriguing and challenging case. If you like this video, we welcome you to share it with your friends or colleagues who may have a similar interest. And please hit that subscribe button so that future releases, whether in GI pathology or GYN or other areas that we like to cover on our channel, will be delivered right to your mailbox. Appreciate your attention today, and until next time, thanks so much for joining us.